Before we get started, please remember that patient-centered care always involves patient education and patient consent, so please involve your patients with all your decision-making and make sure that you are meeting their goals. Please remember always to check your own biases and manage your own countertransference because addiction is a stigmatizing illness and we want to make sure that we're not contributing to that. Remember, this is an educational video, not patient-specific advice. So if you need any questions, you need to talk to an addiction medicine specialist about anything, please feel free to contact them and remember that you are responsible for your own practice. I have no conflicts of interest to disclose. So with all that, let's get started. For alcohol use disorder, we have as our first line treatments, naltrexone and acamprosate. Second line, we have a few other medications like gabapentin, topiramate, and there's a few other ones as well that are less commonly used. And then third line, there is disulfiram, and I usually typically only use disulfiram in very specific situations. So I'm going to get into all of that. One thing to keep in mind, anytime you have a patient with alcohol use disorder, you are going to want to make sure that you have them on thiamine and folic acid supplements to help prevent the development of Wernicke's and Korsakoff's. As we know, alcohol drains the brain of thiamine and folic acid, so please always make sure that you have your patients on those medications. Okay, so first line treatment for alcohol use disorder, we can start talking about naltrexone first. So naltrexone has evidence that it helps with abstinence from alcohol, so it helps curb craving so that people don't drink, but it also helps to reduce the amount that someone drinks if they do continue to use. So it can help to reduce the number of heavy drinking days and the number of drinks consumed on each occasion. So naltrexone can be helpful whether a patient's goal is abstinence or whether it's just to cut down. A couple of things to note about naltrexone. So it is an opioid antagonist, so you cannot be on opioids if you are on naltrexone. What this means is that if you are on prescription opioids, naltrexone is not going to be the best option for you. And if you are on naltrexone and then you all of a sudden need opioids, we need to make sure we use non-opioid adjunct medication as much as possible and then just sort of flood the receptors with opioids with the hopes that we can overcome some of that naltrexone. So for naltrexone, you cannot have an AST or ALT greater than 3 times the upper limit of normal. If you do have those elevated liver enzymes for your patient, then it becomes really tricky. And greater than 3 times the upper limit of normal is a bit conservative. Like some people use greater than 5 times the upper limit of normal, but in Calgary, the way that we're doing it here is typically greater than 3 times. And you just have to use caution. If you're gonna, be doing anything differently than that, you're going to want to do that in consultation with hepatology. Okay, same with cirrhosis. So you cannot use naltrexone in decompensated cirrhosis or in acute hepatitis. Now, naltrexone itself can cause a hepatitis as an uncommon side effect. So we always are going to want to make sure that we're checking those liver enzymes at 1 month, 3 months, and 6 months, as well as yearly post starting naltrexone, just to make sure that we're avoiding that naltrexone hepatitis. And then if that does develop, that we catch it right away and stop the naltrexone. So if someone has cirrhosis and they don't have any other options and they really want to try naltrexone, I would always do that in conjunction with hepatology. I would get hepatology's input before starting that. Okay, naltrexone is once daily dosing, which is really great. It's very easy for patients to remember, and it's just 1 pill once a day. Don't have to think about it. It is covered by Alberta Works, AISH, and other things, so it's pretty easy to get, and it's not too expensive. So that's naltrexone. Acamprosate is also a really excellent medication for helping curb cravings for alcohol. So there's evidence to show that acamprosate reduces it helps to maintain abstinence, so it reduces cravings, but there's not great evidence to show that it reduces amounts when drinking. So acamprosate, you're typically targeting people who their goal is abstinence. Acamprosate is renally cleared, so you can't have renal failure that's really severe, and there's renal dosing for if you have like moderate renal failure. And it's also contraindicated in pregnancy or breastfeeding. It is 3 times a day dosing, which is less convenient. So you have to have patients who are pretty comfortable with 3 times a day dosing. And it does need special authorization for Blue Cross if your patient's on Alberta Works or ASIAN or anything like that. So please make sure that you have discussed this with your patient and that you call the pharmacy and see whatever authorizations are needed for that patient, because acamprosate is a little bit more expensive than naltrexone. The good thing about acamprosate, you can use it in cirrhosis. There's not good evidence for like CHOP-QC, but for that like early stage cirrhosis, you can still use acamprosate. The key is that hepatorenal syndrome. So just checking the kidneys all the time. So in Calgary, gabapentin used to be very commonly prescribed for alcohol use disorder. And the reason for that was that naltrexone and acamprosate simply weren't available or weren't covered. There's less good evidence for gabapentin than there is for naltrexone or acamprosate in terms of curbing the cravings of alcohol, but it can sometimes be effective for some people. As we know, gabapentin does have a street value, and it can be more addictive. So some people do develop a dependence on gabapentin. We just have to be really careful. And then also, if you stop gabapentin cold turkey and in a patient who already has a low seizure threshold, it can lower their seizure threshold and precipitate seizures. So we just have to be really careful with that gabapentin use. Topiramate, there's again not great evidence, but there's a little bit of evidence, so can help to curb cravings as well. The third line treatment for alcohol use disorder, which I really want to talk about because every single patient has heard of it and they are always worried that that's what you're prescribing. So that medication is disulfiram. And disulfiram is a medication that does not affect cravings. So it doesn't help with the cravings. What it does is it provides some accountability for maintaining sobriety. So if you drink while you're on disulfiram and you drink heavily and you're on a lot of disulfiram, it can cause a lot of sickness. So like you can feel really sick, but it can also even kill you if you continue to drink while you're on it. So people throw up, people feel like crap, they feel really terrible. So it is that deterrent effect. But we know that when someone has an alcohol use disorder, one of the criteria that they may experience is use despite consequences. So it doesn't always stop people from drinking just by the nature of addiction itself. Where I've seen disulfiram work well is in relationships where the patient is in a relationship with another person and they are receiving therapy. And as part of that therapy, that person gives them the disulfiram every morning as a sign of accountability. And the patient receives it every morning as a sign of accountability and maintaining sobriety. And for some people, it works really well. They feel like that accountability is what they need and it helps build their relationship up. So it's not something that we don't use. It's just that it is a tricky medication. So it also can have quite a lot of liver side effects. So you just have to be really careful with it. Those are the primary treatments for alcohol use disorder. And I hope this has been helpful. Please feel free to contact Addiction Medicine if you have any more specific questions. Thank you very much.